UCSF. He has interests in neuromodulation for epilepsy and movement disorders, and a particular interest in the EEG findings associated with mindfulness and meditation, which he'll be talking about today.
Thank you so much for that kind introduction, Peter. I'm going to make sure I'm sharing the correct screen. And if maybe Chris, just give me a nod if you're seeing the presentation mode and not the presenter mode. Okay.
Looks good.
So guys, it's such a pleasure, and time really flies. I looked back and I thought it was less than a year that the previous meditation talk happened, and it's been much longer than that. But always wonderful to come together as a department and to catch up on some of these findings and to let you know what the meditation team is up to. As you see from the title here, mindfulness research and neuromodulation, I want to try to stay away from some of these very loaded words, and apparently meditation is one of them. So we'll use those interchangeably. But for now, let's go through the disclosures. Some of these will be relevant to the talk as we use the NeuroPace device in some of our investigations. And I also want to thank the FBI grant that we got a couple of years ago that allowed some of this research to go forward. To me, there's no way to go about this other than doing the thank you slide first. None of this is really possible without my mentors, our collaborators at Sinai and at other centers. And we will be getting back to some of these folks during the talk as well for shout outs. But again, one person cannot do any of this, and it takes a wonderful team. And that's why we're so lucky to be able to accomplish that and set that up here at Sinai. So the outline of the talk will be as follows. We're first going to overview mindfulness practices and meditation, and to try to, again, offset the loaded word that is. Meditare in Latin is really just concentration and contemplation. Human beings are very, very complex. And if there's ever a way to simplify what we truly want, it would be to say that we want to be happy. But it's really beyond this talk to try to cover what each individual, each family, each community means by that. Yeah, too much baggage. Neuroscience has been trying to chip away at this. And really what we do is we define the opposite. We define stress, we define anxiety, ruminated thoughts, depression, and we create scales that then balance those and decrease those. And one of the ways to do this is, again, to talk not about meditation, but about mindfulness and increasing well-being. We do have some reasonable, accurate measures to be able to measure well-being in our patients and volunteers and in ourselves. And that is the way that we pursue mindfulness and meditation research. The one thing that we will have to cover today, that's a bit daunting, would be the default mode network. This incredible circuitry of the brain that is useful for human beings and in our development, but at times can go awry. After that, we will make our way through acute meditation effects and how we can go ahead and research those, and those will be meditative states, as well as long-term meditation effects. We'll talk about those, and we will refer to those as meditation traits. And of course, always the fun future directions, and I hope that this sparks a good discussion. So the main question is, what can we volitionally do as human beings to increase our happiness? This quote right here is slightly misconstrued. This is, of course, the great Leo Tolstoy. What he truly said in Russian was, if you want to be happy, work on being happy. It's understood by the statement itself. Although this translation into English is fascinating, because what this actually says, if you want to be happy, be instead of do, stressing the idea of just being instead of being in the usual rat race that we are in our busy lives. He really was the mover and the thinker of bringing Eastern philosophy to Russia and slowly spreading that through literature to the Western world. But what can we really think of mindfulness as contributing to our well-being? Well, this is all based on scientific studies: improved attention to detail, increased resilience, ability to task switch, what we previously would call multitasking. That's actually a myth, but the ability to switch from one task to another rapidly, which gives the appearance of multitasking, is something meditation and mindfulness can help with. Rapid cool down from a stressful situation, again, incredibly important in our busy and complex lives. And meditation and mindfulness will allow you to do this. And equanimity, And again, this is the word that we use a lot in neurosurgery, this ability to withstand stress, the ability to appear poised under pressure. All of those things most certainly can improve in us. And one of the ways to do that would be through mindfulness practices. And here again is the reportedly happiest human being in the world, Matthew Ricard. Started out as a scientist in Europe and then went over to India and Tibet and became a practicing monk. And a lot of the research that we're talking about today and have talked about previously has to do specifically with his brain and the findings of that brain. So let's go a little bit further back and try to see how and why meditation and mindfulness practices are sticking around in our gene pool. There's got to be something good that they do to us. They've been around for over 7,000 years, and that is our best estimate. And we base that on statues and meditative positions. So we know that meditative postures have been around pretty much predating literacy and the ability for us to record these. Now, what we also have is the just persistence of this in many cultures and religious, and also outside of religious practices. And here, what I want to point out is that the removal of the religious stress and goals, like is done in mindfulness-based stress reduction courses, which are founded by John Kabat-Zinn. This is about 50 years or so ago. Probably the strongest a-religious research is done in that field. And those are courses that are available for us as Mount Sinai members, both attendings, physicians, students, residents. And I would highly encourage people here, if they have not yet, to go through a mindfulness-based stress reduction course. And the other one that we may spend numerous lectures and arguments on would be the fact that mindfulness practice may be at odds with some of the social structures that we currently maintain. To quote Dan Gilbert from Harvard, you know, a shopping mall full of Buddhist monks is really not going to work. They just don't want stuff as much as sometimes is required for a system that runs on capitalism. That's a bridge we're going to cross when we get to it. As of right now, objectively, we do think that human beings will be better off if we practice mindfulness. So let's just accept the premise that well-being, stress on well-being, and the want and meditation ways to get there have been around for a very, very long time. So we kind of know that we can and should do this, but what does truly happen? Well, it's the same as exercise. It's the same as, at times, personal hygiene, preventative medicine, healthy eating. There's a component to us that knows that these are good. Yet all of those are immediate effort and foregoing of a potential immediate reward for a future vague and greater reward. If there's ever been a group that could truly embrace this concept of delayed gratification, I think it's the neurosurgical team. You know, we work long, stressful hours at the expense of friends and family, pretty much make as much as a good waiter about 11, 12 years out of college, all in the hopes of achieving happiness by accomplishing fairly vague, initially, future goals. We most certainly will delve further into the potential harm that approach does to all of us in humanity and in our profession. Stressful lives with a hope and happiness placed in the future, stress and anxiety fixed squarely in the present moment. So meditation is on this list, right, of the things we really should do. And we now have significant scientific basis to say this, and we don't. We don't, and here's a first book plug for today. If you haven't read this as of yet, a little bit dated, but a great description of human beings as algorithm-solving entities that have significant tension currently between our genetic inheritance and the modern world. And the overdrive of some of these incredibly complex and interesting brain systems that are evolutionary advantageous to us, but can be misused. And here we want to introduce you to the default mode network and the serendipitous discovery that caused us to be aware of this so we can start working on it. So this is an amazing tool. And the way that we came about even knowing that this existed, this is only about, 1997 was the initial discovery, is during fMRI experiments, the scientists needed a control. So they asked the patients to rest and just let their mind wander, to be inactive. And all of a sudden, surprisingly, they saw that the fMRI shows significant signal and significant working of the human brain when human beings are asked to just be at rest, and to let their mind wander. So there were two kind of main theories of this. So was this one of those systems that is just shut down by tasks and allows our brain to sort of continuously live and rest? But the other idea was that this is a distributed set of regions that is really involved in a specific type of thinking, the type of thinking that we go to when we are not distracted by outside tasks, when we're not maintaining outside attention. We can think of this as the experience generator for the human brains. And here you can see the default mode network, which includes inferior parietal lobule, hippocampal formation plus, both ventromedial and dorsomedial prefrontal cortex, posterior cingulate, retrosplenium, and parts of the anterior insula. So as the experience generator, what this system allows us to do is incredible things like mental time travel. You know, we do not have to go on vacation and think how that's going to be if we choose Antarctica in the middle of winter. We kind of know it's going to be a bad idea. We're able to project our days, project our weeks. We're able to have reveries into the past and into the future to really guide us in our decision making. It's an incredible tool that really does separate us from other beings that we share this planet with. We're replaying these live episodes. We can prognosticate future events. As we said, it's really not to get too Freudian about this, but this is the story of the ego, the story that we all tell other people when we say, well, who are you as a person? Unfortunately, when overused, and there's now data to support this, this causes significant anxiety and actually decreases our well-being. We'll delve more into why. So this is misused by human beings because now we have this significant lack of perceived threats as we move around our daily lives. And just think about the amount of times you've almost run into somebody on the street when you're both on your iPhone, catching up on something that you need to do for work, planning the future days, really just trying to be as involved as we can. And again, the default mode network settings of what do we have to do next, the doing and not the being. The rehearsed and repeatable actions of our lives really get streamlined by the brain to use as little energy as possible by the brain, to use as little attention. Next time you're brushing your teeth or swiping the Metro card, pulling out of your driveway, just take a look as to how you do it. Most likely you are doing it exactly the same way you have done it for years. Those events are repetitive and they are identical. This conserves this incredibly precious resource, which is going to be a big deal for this talk, and that's attention. Human beings have limited resources in their brain, and we want to make sure that we put our attention on the thing that truly matters. Again, unfortunately, when our minds are free and allowed to wander, the current system of default mode network tends to take over. Now, at times we do need to relax and break the cycle. And some of this right here is historical and some of this is funny. And some of this is harmful to us as human beings. So how do we deactivate this network? How do we take a break from this sort of mental continuous rat race that we sometimes have to get into? Well, novel, non-self-referential, goal-oriented tasks are one way to do it. And here we can think of truly being in the groove in a surgery, wanting to accomplish a specific task and focusing our mental energy and attention on it. The other slightly less benign ways of potentially doing this would be alcohol. And we have research from the last few years to show that alcohol does significantly depress the functional connectivity of the default mode network. It allows us to take a break, albeit of course at a significant price. As we know, the health effects of alcohol are significant. The other interesting avenue of research is psychedelics, and what psychedelics do to the human brain and how they do break down the default mode network. And that's including LSD, psilocybin, and DMT, which is the active component in ayahuasca. A lot of research over the past 20 years has been done now on the similarities between psychedelics and meditation. And we can, for all intents and purposes, think of potentially psychedelics as a shortcut to show human beings what a high level of a meditative state would be in the future, and potentially allow us to have that goal to aim for as we go through a fairly laborious process of getting there using mindfulness meditation. And as you guys can see here, so as we go via this shift of switching off the default mode network and trying to get into a more attentive state, attuned to the current being, we see that we're actually activating anterior insulin and a few of the other areas as we become aware of the fact that just a moment before we were not. And the best way to illustrate that would be if you're driving completely on autopilot and all of a sudden something really attracts your attention. There's a car accident in front of you, the light changes from green to red, you snap back to it. And if at that moment you think of what the previous 5 or 10 seconds were, you may not be able to recall it. Again, you were somewhere else, you were using your default mode network for planning, and you really were not attending to the world. The name of default mode network itself, I just want to clear up, is a little bit misleading. Again, initially it was found to be the system that is there at rest when we allow our brains to mind wander. Most certainly, this is a very important system. Self-referential model building, planning for future, generating possible future experience, and then rejecting those paths based on their possible outcomes and rewards. So I guess the best way to think of it would be, it's a system that supports internal mental stimulations. And then that can be used adaptively in our lives. So not all bad, but most certainly can be misused. And here's a comparison of other networks that do exist. We have a network of executive control, salience, dorsal attention, auditory and visual attention, sensory motor attention. So we know that this is just part of what our brains do. Yet again, it's becoming more and more prevalent in the current day and age to abuse the default mode network. So now let's get to this concept of meta-awareness and how do we break out of the default mode network. And this would be thinking about thinking. If any of you have ever tried to meditate, there's most certainly going to be a moment in the first few minutes where you go, and there I was again, somewhere else, I should be meditating. So that moment of meta-awareness is really important. And a lot of the studies are really basing their switching inside of the brain on that moment when you are aware that you floated away somewhere else and you need to bring your attention and your focus back to meditation. And hopefully the goal here, right, is us as scientists and neuroscientists to discover why chronic meditators are happy. Now that takes a while, and you guys can see why the limitations of these experiments are significant, right? There are incredible Buddhist monks that have done over 50,000 hours of meditation in their life. And yes, their brains look significantly different even at rest. We're going to call that from now on trait changes. They, walking around in the real world, have brains that have the appearance of somebody who is acutely and continuously meditating. And that's research that's led by Richard Davidson, one of our collaborators over in Wisconsin. Here's a picture of Richie in an MRI scanner with Matthew Ricard, some of this early research to show us and tell us that once you reach that state, once you pass 10,000 hours of meditation, your brain at baseline will be different. It will be able to handle stress better. It will appear, for all intents and purposes, to be a younger brain. And it will allow us to potentially reach some of these goals as we discussed before: equanimity, resilience to stress. But what can we do to help us busy human beings get there, or at least start getting there? How can we study the acute effects when most of us do give up the first 10 hours, the first 20 hours, the first 100 hours of mindfulness meditation? What can we tell human beings about the acute changes that may be happening to really reinforce the fact that they are doing the right thing, they're going to get there? So that is really the focus of part of the experiments here at Mount Sinai. So what I want to do is a quick thought experiment, is again, just to restate the differences between state and trait changes whenever we do the scientific experiments. So state changes, acute effects, no carryover to the steady state. You do something, you come back to baseline, you do it again, you come back to baseline. So if you think about this as the curve, and you have your first meditation session as this blue line, you have your second meditation session as that next blue line, and you can see that our brain is different for time, and then it floats back to that baseline. So you can see that the green line of state changes improves. You can get better at that task for sure. The 5th, the 10th, the 1000th time you meditate, you will be better. Your brain will reach that area faster, that state faster, but the baseline will stay the same. Now, trait changes are different. And you guys can see that in an experiment, we want to look for trait changes in a different portion of the experimental paradigm. These are chronic effects that move the baseline of the steady state. So here's an example of what a trait change as well as a state change graph would look like. So here you have your first meditation session. Here you have your second one. And you can see the state changes are improving, but also what's happening is the baseline, when you're coming back for your next meditation experiment, your brain is already slightly different than it was before. And that continues to build. This is a quick joke here, just to make sure people are still awake. So you can think of spine surgery as, you operate and they come back to you. You operate and they come back to you. You get them better and they come back to you. Whereas brain surgery, we're chipping away at that tumor, we're getting them better. That is really hard on Zoom. So let's move on from that. Default mode network deactivation, right? So again, how can we get to these trait changes? How can we get to these state changes? So one of the incredible patient population that we all get to work with is drug-resistant epilepsy. And the reason why they really hit such a sweet spot for us to be able to pursue this research are their comorbidities and the ways that it is right now medically appropriate to work them up. So a quick review here from about 5 years ago by Nathalie Jeté, one of our epileptologists here, shows that up to 40% of patients who have drug-resistant epilepsy will have psychiatric comorbidities that are severe. Anxiety, depression, tends to be that younger patient will have anxiety, older patient will have depression. So there's potential that there's something about seizures and epilepsy that causes them to go through the anxious state first. And then as the disease unfortunately solidifies and progresses, they see no way out and they become depressed. The thing that they key in on continuously is the unpredictability of seizures and the anxiety that that causes. The number one concern for the drug-resistant population is anxiety that is caused by a disorder that is so unpredictable. And right now, unfortunately, there's really no systemic approach to the treatment of their anxiety. We know that it works. We know that it works for other things. I apologize, the lights. We know that it works to decrease stress and anxiety in other populations, but right now there's nothing that really exists for that in epilepsy. So what we're able to do at Mount Sinai is we're able to utilize the fact that these folks will come in and they will spend several days to several weeks with us here with intracranially implanted leads. And you can see the stereo EEG implant here. And serendipity-wise, the circuits that we work up are the circuits that are very similar to the circuits we've discussed previously. There's contacts that are going to be there for default mode network analysis. There's contacts that are going to be there for attention and limbic circuitry, because a lot of those circuits are involved in seizure spread. Now, of course, we're limited for the duration of these experiments by the time that these implantations are here at the hospital. So anywhere from about 1 to 2 weeks to be able to research and contribute to science with these folks here. And here I want to do a shout out to Elizabeth and Zara. So they've been leading these experiments under the guidance of Ignacio Saez at the lab at Mount Sinai West. And we're really trying to figure out what are the initial barriers to meditation. And it seems that the key concept in all meditative and mindfulness practices is the initial gathering of attention. And that's what we're keying on currently. How do you let the rest of the world go, your tasks for the future, your reveries of the past? How do you focus on the here and now? And one of the best ways to do that is focused awareness, focusing on your breathing, focusing on a specific spot in your body, and trying to maintain that attention. The goal here, of course, is how do we study this to potentially augment, support, and guide novice meditators before they give up and say, this is not for me. Now, of course, there's pathologies that make this even more difficult, almost impossible for an OCD patient to be able to meditate. But again, we have the patients here and we have an amazing center that may slowly guide us to some of these answers because we're now developing the intracranial access to the brain of some of these folks. So here is a brief rundown of what meditation in the EMU with stereo EEG and EEG at the same time looks like. As long as they do at least one session while they're here with us, and we actually want them to be novice meditators, we want to split declarative learning and active learning. It's okay if they know about meditation, but we prefer them to not have meditated in the past. Active control is incredibly important for these experiments. And the way that we've designed active control here, again, with the help of Dr. Davidson, is they are learning about meditation and how it works without actively meditating. And boy, do we see a big difference. And that's another reason for all of us to actually meditate and not just study meditation. There's a huge difference between learning and reading and embracing meditation as a scientific pursuit and actually physically meditating. And we'll show that to you guys. So that's 5 minutes at the beginning of each experiment. And then after that, we do focused awareness meditation for 10 minutes, compassion or loving kindness meditation. That really revs up the limbic circuit. We'll discuss that later. And then we do a couple of minutes of mind wandering cool down. The reason why each one of these is here is, again, for us to be able to eventually get to both the traits and the state changes of these patients, right? So a state change would be a comparison of our baseline to the actual middle of compassion meditation. A trait change would be us comparing our active control when they come in for the session to their active control at their 10th session or 100th session, or potentially repetitive meditations in the EMU as they're here with us for these days. So far we've had 5 people undergo these meditation experiments in the EMU. The analysis, as you understand, would be extensive, right? This is sampling frequency of 2000 hertz, 24/7. The amount of data that needs to be reviewed for this is a lot. So this part is not ready for prime time as of yet, but I do want to bring your attention to a fun thing that we are writing up from this research. So here are the leads of one of the patients that has undergone this. And you can see that there's 3 contacts in the amygdala on one side and 4 in the other side. There's also contacts in the anterior insula on the left. And what we found here is this bright spot on the power spectrograph. And initially we were just fascinated by what was happening until we debriefed with the team that was doing the meditation, and we realized that this is one of the few patients who have had a seizure while undergoing meditation experiments really in the world with intracranial electrodes. So we're currently writing this up. You can most certainly see that the power spectrograph here changes at about 5 minutes, and we have video footage, and this is loving kindness meditation. So we know that most certainly meditation increases brain activity. And there's a lot of arguments in the literature and in the community as to, does it increase potential for seizures? Does it decrease it? Now here, of course, there are caveats, right? This patient was already off their seizure medications, at baseline, a very anxious person. So we do think that there's reasons for this. I do not think that this is in any way a red flag. If anything, it's a way for us to promote what we want to happen in the EMU during stereogy. We want them to have seizures. So what I want to do now is switch over to the long-term experiments, right? So what can we do once they leave the epilepsy monitoring unit, once they're there, again, out in the world? How can we potentially keep track of what is happening? And here, Leah, one of the doctors from South America who's volunteering with us, has been leading this and really trying to delve into how do we fight these issues, right? Difficulty with chronic recordings. There's very few people walking around out there who have implanted electrocorticography that is going 24/7 and can be accessed. Years potentially may need to be spent in practice before we show some of these effects, especially trait changes. And we really need to work on bridging this gap, right? We have these monks who have meditated for tens of thousands of hours, but most certainly it's not an ethical experiment to have a stereo EEG or responsive neuromodulation in their brains. So we have to bridge that gap between extracranial and fMRI data and also intracranial data that we have. Well, again, we're lucky to be here at Mount Sinai, and we have the biggest group of patients implanted with responsive neuromodulation, as you guys can see here. Most of you are probably aware of this from previous lectures. This is an augmentation to seizure treatment that allows us to capture seizures and prevent them from spreading by closed loop stimulation. What it also allows us to do is a window into the human brain, really at any moment that the patient would allow us, and any moment that the research team could set this up. So here's an example of a long-term experiment that is run by one of our friends, Vikram Rao at UCSF. This is focused on seizures and what we found from that. It's fairly complex, but we'll go our way. We'll make our way through this. So the implant is shown in A. We can see that we can capture what we call epileptiform discharges on responsive neuromodulation, and you can see that in B. We can count those over days, over weeks, and over months. And then what we can do is we can actually predict seizures for these patients because we see that patients have specific rhythms to when their brains are more likely to seize. There's normal circadian rhythms. So as you can see that there's a little bit of a spike and a dip and a spike and a dip for these patients as they go day to day. You guys can see my mouse. But at the same time, we can all appreciate that there's an underlying oscillation and a curve. And if we zoom out and go to E, you can see how incredibly persistent these curves are inside of each patient's brain. So what Vikram and their team was able to do is to really start leveraging this to warn patients that they're about to have a hot episode. Maybe it's time to increase the anti-seizure medication, maybe not travel that weekend, versus other times that we know in their personal rhythms, they're not about to have a seizure. So we can see now that this kind of analysis, again, accessibility and the ability of this device to record and give us feedback is an incredible window to the brain. We're also lucky at our center to have a lot of these implants that have contacts in the amygdala and hippocampus, which is one of the key circuits that we want to study for meditation, specifically for compassion and loving kindness meditation. So the experiments that we're running here with Dr. Mayberg's help and Dr. Waters' help is bringing these patients back weeks, months, and potentially even years after their RNS implantation. Right now, screening into patients who have amygdala leads and going through the meditation paradigm with that using this incredible QLab that Dr. Mayberg has set up. That is not somebody who has an RNS in their head. That is me kind of running through and seeing how this would work at the center that we have over here at Mount Sinai West. So here's an example in a very busy power spectrograph, but I want you to focus on the blue line here. So these are different sessions as you go session 1, 2, 3, 4, 5 of one person who has now meditated with us at this point over, I believe, 7 times. And right here is his responsive neuromodulation implant. Right here are his contacts in the basolateral amygdala, and that is the trajectory that gets us the most hippocampal coverage. So just by nature of how the lead is placed, we end up in the basolateral amygdala, usually with contacts 1 and 2. You have the blue line over here up top. That is our active control. That is them learning about meditation, going through a recording or one of our psychologists live doing this. Adam Saad is one of the folks that leads this part. Again, they're learning, they're not actively meditating. And then down here in the purple line, through all of these, you can see that they're going through focused awareness, and then they're going through compassion meditation. So if we were to look for a state change, something that should be the most easiest to see, really to let us know that these experiments are working, we want to compare the active control to as far into meditation as they have gotten. Think back to those curves that we discussed, right? We want not just the state to be higher, but also potentially the trait that has caused now their state to be higher. So we're comparing these two right here, active control in the first session, and then compassion meditation on the latest session that we have here, which will be session 5. And here we have to thank a wonderful researcher on Ignacio's team, and that is Christina Maher. So she's been able to really analyze this using this new algorithm called the FOOF algorithm. So we're comparing this now, and we're trying to really erase some of the potential errors that will go into this data analysis. And here, if I can play this, so this is where the leads are in the brain bilaterally, amygdala and hippocampus. And we're really trying to compare periodic and aperiodic properties of electrophysiological signal here during this compassion, loving kindness meditation compared to active control. The standard neuroscientific approach would be this 1/f graph that shows you the power spectrograph. But now instead of just looking at the slight differences in the colors that we saw on the previous slide, we are able to just differentiate this better. And this is one of the studies that we're following. This is meditation, but chronic meditation, and the changes that are seen in everything from beta to high gamma in frequency and power as you are continuously practicing the meditation. Another way to look at this, what I'll show in the next slide, is going to be to really focus on a certain frequency, let's say somewhere around beta or low gamma, and to see what is the difference between the active control and the meditative state. This really allows us to separate out, again, the oscillatory activity and the baseline aperiodic activity. So this is the work that Christina just forwarded to us. This is hot off the presses. And you guys can see that there's a significant effect of loving kindness meditation on amygdala activity. And what you guys can see that the frequency is centered somewhere around beta. You can see the power magnitude here. And then this next graph shows the center frequency decreases a little bit versus control. You have the power of the frequency that is significantly greater in loving kindness meditation, and you have a greater bandwidth. That previous graph showed all of those findings for us. So this right here really just solidifies the pilot data for this project to say we can live on an outpatient basis at any moment in the life of that specific research subject, have them meditate and get feedback that that meditation is working and it is activating their limbic lobe. It is exercising their amygdala. And think about it as any other exercise, right? You run a lot, your resting heart rate drops. You exercise your amygdala with loving kindness meditation and compassion meditation. And at baseline, the amygdala activity may be dampened, allows you then to exhibit more equanimity and more resilience under stress. Now, how can we relate that to the actual patients? What are they feeling? What are they going through? Because right now, truly what we have outside of EEG and fMRI are the subjective patient experiences. Have they gotten into a meditative state? How well do they think they did? Were they just really thinking about the World Cup the whole time? And what we have here, again, this research is driven by Adam Saad, one of our wonderful neuropsychologists, and he modified the anxiety questionnaires to make them a little bit more current. And we have folks go through these anxiety questionnaires before their outpatient experiment in the Q lab and after. And you guys can see premeditation in yellow, questions like I feel fearful, anxious, worried, hard to focus, nervous, uneasy, and tense. And you can see that there's a significant drop in those after they go through their meditation session. We're about to standardize this and start using apps, which will make this easier to record. Right now, unfortunately, it's still a lot of manual labor on the part of the team to be able to accomplish this. But I think there's a way to streamline this heading into the future. So as we said, this improved amygdala response to stress. What does this potentially do to us as human beings? Is this one of the reasons why mindfulness meditation and compassion meditation actually improves our overall well-being? So as we said before, amygdala dampening may be useful in inherently stressful situations to maintain logical thinking, maintain the ability to task switch, and most importantly, not to be dreading a specific event in the future, let's say difficult surgery, and then not to be coming down for days or weeks after a horrible event in the operating room or a stressful interaction with a patient on the floors. Chronic meditators are able to fully engage the limbic circuitry. They are fully there and they are experiencing this, but they don't go through the same level of anxiety before the event, and they are able to rapidly cool down and task switch after the stressful event. Maybe this is something that we can all aspire to, and maybe compassion meditation is a way for us to get there. So again, another plug. I know we did this a couple of years ago, but there's this incredible gentleman, Alex Honnold, who climbs El Capitan without a rope, and his amygdala on an fMRI just does not fire to fearful stimuli. He just does not react. There's a little bit of autism in his family, and there's a component to this that is most likely to be still yet psychologically fully evaluated. I don't think that any normal human being that we know of would be able to do this and to be able to spend 3 hours and some climbing this wall without a rope, knowing that any small mistake is instantaneous death. But highly recommend checking out this movie if you have not as of yet. But can we at least approach this? Can we get partially there through meditation? And then can we potentially, we're surgeons, we're neuromodulators. This is, this is a great center for neuromodulation. Can we somehow affect the circuitry to aid and guide these folks to get there sooner, to give them a little bit of a shortcut? Can we modulate this circuit, as we said before, right? This circuit that snaps you from mind wandering and default network to an attentive state and a focused state includes the anterior insula. And we're going to have some great experiments here led by Alison Waters that are really focusing on anterior insula stimulation and also anterior insula signal recording during stereo EEG in combination with breathing exercises, interoceptive exercises, and meditation. So future directions for this research. It is almost too much to even put onto one slide, but to summarize this, we now know meditation and mindfulness works. It can make us better at our lives. We really want to study the state changes followed by the trait changes. We really want to see how this curve develops and where are the pitfalls in the curve. Maybe they come at 100 hours, 200 hours. Maybe you really hit a wall at about 1,000 hours. But hopefully you guys have seen now that in combination of stereo EEG and chronic ambulatory ECOG recordings, we potentially have access to the human brain throughout the duration of this incredibly complex learning curve. We may have the ability now, right, to record acute changes in default mode network, attention and limbic circuitry. We may be able to influence those, right? These contacts are not one way. These contacts are used for intracranial mapping at the end of our stereo EEG. We are mapping these human beings. We're seeing what stimulation in certain areas in the brain does. Now, on a clinical level, that is for us to try to trigger a seizure or to trigger after epileptiform discharges, which is a sign for us that we're close to that correct network. Most certainly subthreshold stimulation to try to get some of the answers we've discussed today is feasible, and we're going to be pursuing that at Mount Sinai. The next one, of course, is this ability to record chronic and acute changes in long-term ambulatory, and this would be RNS, but we're reaching this over to DBS as well. The new DBS devices allow us also to chronically record and be able to give us that feedback, although the areas from which we're sampling are going to be significantly limited to the classic DBS targets. So interoception and attention investigations in the anterior insula are going to be led by Dr. Waters and her lab. Facial analysis to guide meditation, another fascinating subject that could cover several hours of a lecture. We now know that your face changes when you're depressed, not depressed, when you're attentive, when you're empathetic, sympathetic, upset. What we want to do is we want to bring experienced meditators into the lab, record their faces and their level of depth of meditation, and then compare that to novice and young meditators and give them biofeedback to say, aha, right now your face is exactly like the face of that Buddhist monk. Is there something that you just did inside? Is there a depth of meditation you just reached to that you haven't before? Please continue pursuing it this way. So behavioral feedback based on chronic meditators and their facial expression during deep meditation states. Short-term stereo G experiments for attention circuitry, right? So this is that initial onset of meditation. How do we get into that state? How do we maintain it longer? Can we use neuromodulation to get there or to keep us there? Long-term meditation with RNS. And here we're going to be leveraging a Healthy Minds app that I suggest everyone on this phone call download. It's free. It's an incredible research effort by Richard Davidson over in Wisconsin. And it allows you to really get into meditation and to have it be tracked and to have little reminders, completely unobtrusive to your life. And to testify to that, I have an open mind in about 3 months and I'm guilty of it, but I highly suggest everyone try this. And of course, this incredible possibility of default mode network disruption with psychedelics and with neuromodulation. And that effort is now ongoing. A couple things to pitch here forward. This is the Healthy Minds app, and this is a great book by Michael Pollan, How to Change Your Mind, really delving into the history of psychedelics and how they can potentially be used in addition to meditation to be able to really open that window for us and to let us know where we should be and where we can be if we continue our meditation practices. So at this point, again, I would love to thank the big team that is included in accomplishing this. And it's wonderful to see and hear the interest that was ignited in the department a few years ago when we started these projects. We invite anyone and everyone who is interested to participate and to help us in any way that they can, because most certainly we need that. We need fresh ideas and we need to be able to push this forward on a much larger level. So at this point, I want to thank everyone for the opportunity, and I want to just open it up for questions and other ideas. Thank you, everyone, for your time.
That was beautiful. I really enjoyed it. It's great to see your work progressing like this, Ted, from passion to science and follow through. If I could open up with a question relating to other modalities. You started with the discovery of the resting state default mode using functional MRI scan in non-invasive method of understanding circuitry, and then you progressed towards what we can learn from a more invasive method. There are other non-invasive technologies now, for example, TMS and lo-fi, hi-fi, HIFU, lo-fu, HIFU. Once you learn the circuitry, could you use these non-invasive methods to activate those same areas and create this sort of state that you can get on your own by meditating? Or could you record those non-invasively with TMS recording devices and other non-invasive methods?
Yeah, absolutely. We just came back from a great conference, American Epilepsy Society, just down in Nashville, and the excitement about specifically LoFu. So this is a low frequency ultrasound, a reversible way to stimulate the brain accurately. And to me, that is a little bit more promising than TMS. You know, TMS is fairly limited to the reach that it has, so it's harder to affect deeper areas, and the accuracy is just not as good as we can get with some of the other states. But LoFu has incredible potential. So as an example, they are now using it to treat the hippocampus, and they see that up to 6 weeks, patients are seizure-free, and then they recur. They also know that it is safe because they've done it before anterior temporal lobectomies 2 days before. Then that brain tissue gets removed, and we know that with that level of stimulation, which is about a factor or so below HIFU, which is the treatment version of focused ultrasound, they're not seeing any pathological changes on brain specimens. So we know that it's safe and potentially we can use this, and volunteers are currently going through these paradigms. The goal, I think, here would be to get as much information as we can from intracranial recordings, which give us incredible spatial and temporal resolution, and then start moving outside of the realm of intracranial, bridging it to high density EEG and then LoFu, and eventually just EEG, and eventually just hats that we all wear that allow us to be meditators.
We don't have a LoFu yet, though, right?
We do not. No, it's it's a good amount of investment, but it's something that could really benefit so many parts of our department and other departments. The research that would be here if that existed would be incredible.
Maybe the next generation of RNS is going to be a LoFu emitter embedded in the skull instead of a lead in the brain.
Yeah, so that's the development of that is there. So they do a burr hole.
Wow.
They place a source of energy there, and they're able to at least go through these experiments right now. So yeah, the sky is truly the limit with a lot of this research, and it's fun to be a part of it.
No kidding.
Holly asked a great question in the QA, which is, have you discovered how many sessions it takes to go from acute to chronic meditator? And what is the duration of a session for your subjects in the study?
Thank you, Holly. Yeah, so that's one of the key questions to us, right? When and how do we really go through this learning curve? Is this learning curve one of those things where you're going to be great for 5 hours and then you're just going to completely hit a wall and give up on meditation? So it's not necessarily going to be like the two curves that I showed, right? State improving continuously, and then your trait improving continuously as well. It may be that you actually hit significant pitfalls. You may actually get worse at some of these things as we go through this. And the reason why we think that is, again, revving up the limbic circuit is risky, right? So when we go through compassion and loving kindness meditation, patients feel a good amount of anxiety. They feel better afterwards. And you see, we had one patient who was anxious that she had a seizure during this. So the short answer is we don't know. We most certainly know that once you are past 10,000, or as we see 50,000 hours, your brain at baseline will be significantly different. The study that we want to do is to learn what happens during the first 100, 200 hours. And our best window into that would be repetitive stereo EEG experiments. So having them meditate every day, or potentially have them go through a mindfulness-based stress reduction course before their stereo implantation, which is an 8-week course, then bring them in and compare them to novices. That could give us some of the guidance as to, Holly's question. How do we get to go from novice to experienced? We don't have that answer as of yet, Holly. And as folks are coming up with other potential questions, I want to fire this off to the residents. I mean, I hope you guys see how much of a paid forward this potentially would be. And there is availability, if we make the time for it, for you guys for free to take this mindfulness-based stress reduction course. It would be once a week for a couple hours in the evening, but you would have to commit and you would have to mindfulness meditate for about 45 minutes a day. It's a lot to ask. I personally took the course. I personally did not meditate for 45 minutes a day, but it made a significant difference. So even if you just go through the course itself, 2 hours a week, and then one weekend 6-hour session of silence contemplative meditation, I really want to see this happen for our team, because I know how much stress the crew is under and how much I think you would benefit from this. And we can split this up by years. We can have PGY2s go through this, and we can just kind of slowly build it through the program. But I would love to hear from the residents if they think this would be useful, because everything we've heard of so far, to me, would make you a better neurosurgery resident.
It would have to be taken out of the work week, not added to it.
Yeah.
You can't just add an hour, even 45 minutes to the workday. Chris, what do you think? How does this dovetail with the resident wellness program?
I think the time input is the biggest challenge, obviously. Where can you get that time? But it sounds like there is established benefit, and time and repetition. Just like, as you said, Ted, kind of working out physically, this is working out mentally.
Yeah, well, how about this, guys, to sort of bring this full circle? So a much shorter time of meditation is equivalent to a few hours of sleep. So can we somehow leverage this into the idea that, again, you are paying it forward a little bit, but 30 minutes of contemplative meditation, and we'll get you the research to kind of back this up, is actually going to be as refreshing as potentially fitful anxiety laden sleep. So yeah, to me, it's worth trying to figure out initially on just a volunteer basis outside of the 80-hour work week. Maybe then taking that back to the rest of the team if we truly see those benefits.
Any other comments or questions?
I have one here from Laura Marcuse. She's saying that, yes, speaking on behalf of neurology and epileptologists, she would second getting the LOFU because the capabilities would open up some really interesting avenues for intervention. Yeah, this is everything, as we said, and Dr. Germano, I know, is interested to be able to open the blood-brain barrier, to be able to, just imagine, we are able to deactivate any area of the brain temporarily and reversibly. We can map the entirety of the human brain with this technology from the perspective of function. And we can match to it mapping of the human brain electrophysiologically with stereo EEG. And there's a few other ways that we can also potentially do that. So that would be
the last time I met with the CACT group, I proposed that someone, and I don't know who that would be, lead a group of Mount Sinai scientists to put forward the case to invest in this. But it would need to be sort of full thickness, touching on all the different areas, and would involve many people. It's a lot of work, but I don't see someone like me just, asking for it and then getting that amount of money. I think it's $1 or $2 million. It's primarily for research at the moment. And it seems to have a lot of promise, but we would need to put together what amounts to a pitch deck to review the technology, where it stands now, what are the different areas that it could be applied. And with that in hand, then we could start to look for philanthropy or other methods to pay for it. I'm happy to stand behind that and even lead it, but I can't write it.
I think that's great. Let's start this right now, and I'll send a quick email to the department and maybe also just stretch it to the researchers and the Friedman Brain Institute. A lot of folks would love to have it. So I think it's just getting them together and getting them to discuss this. And as you said, coming up with great projects and possible grants, and then heading back to you and letting you know kind of how that would work
Yeah,
out.
I'm happy to meet with the group. Once you assemble it, you can include me.
Wonderful. There's one from Neha here. When we know something like meditation is good for us, what makes it so hard to stick with? Do apps work as well as guided instructor-led meditation? Thank you, Neha. So absolutely not, right? Guided instructor-led meditation, there's so much peer pressure, especially if you're in a group sitting there to do this. And this is one of those things you can't fake your way through. You can study it all you want, but unless you actually physically do it, it's not going to have the same effect. And right now, the only reason I have is, again, we are just human beings that are really, it's really tough for us to let go that instantaneous reward and to be working for something in the future. Working out, as Chris said, same thing, right? Eating healthy, same thing. So it's hard to stick with because the rewards are potentially in the future. But what I want to stress is they're not as far in the future as we think. And, after 8 minutes of meditation, they're seeing brain signal changes. So you can try this on yourself at home, as I know Holly does, to be able to get this to work. And then Melvin says, it's important to study with regards to treatment of patients with PTSD. Absolutely. I mean, anyone who has gone through spine surgery should meditate for sure. I mean, the PTSD in that field is tremendous. All kidding aside, we're going to work with Jeremy and a few of the other folks. We're trying to work already with Chris and his stroke recovery patients. I cannot think of a single human being except the Dalai Lama for whom additional meditation probably will not be helpful.
When I was in high school, there was a program called TM, Transcendental Meditation, that stormed through our high school. And the trick was getting your word that you had to repeat. And you'd sign up for it. And if you proved yourself, they'd give you your meditation word that you would repeat. And it was for 15 minutes at a time. And I did it for a while. You certainly saw the effect. It was supposed to be more efficient than sleep. But this has been around now for many, many years, even in our culture.
Yeah, I think the heaviest meditator that I know of in our group, probably from the attendings, is Brian. So he does mantra-based meditation right here at Mount Sinai West. So for sure, there's a lot of interest and there's a lot of ways to leverage this and to spread this. Well, guys, I want to thank everyone. And again, please reach out if you're in any way interested and you want to pursue any and all of these avenues. We're literally able and willing to do this every day at Mount Sinai West, but we definitely need help. Thank you.
Thank you, Ted.